the dynamics of the team, but more importantly, the relationship that we build with the patient and the family.
Sono rimasto particolarmente colpito dal pronto intervento ogni volta che avevo necessità, sia a livello fisico che psicologico. Il personale interveniva sempre con molta affabilità, quindi molto gentilmente. Mi sentivo veramente accudito e protetto in ogni momento della giornata. Quindi da questo punto di vista sono rimasto molto soddisfatto. Venivo inoltre informato su quegli aspetti clinici che avrei dovuto subire da quel momento in poi, quindi mi veniva spiegato nei dettagli cosa avrebbero fatto e come lo avrebbero fatto. Al momento del risveglio non avevo ovviamente le idee molto chiare, stavo vivendo due realtà diverse, una quella vera in rianimazione e un'altra che era quella degli incubi, per cui il primo periodo non avevo ancora capito bene quale delle due era vera. Solamente dopo aver parlato ripetutamente con i medici che mi rassicuravano e mi spiegavano appunto questo fenomeno degli incubi e soprattutto anche dopo aver parlato con mia moglie al telefono, ho capito qual era la vera realtà. Le due realtà erano vissute ambedue dentro il reparto, quindi per me era difficile distinguere. L'ingresso di mia moglie in terapia intensiva è stata una inaspettata e piacevole sorpresa. Non ricordo molto di quel momento, le parole soprattutto, però ricordo benissimo le sensazioni e lo sguardo di mia moglie. La terapia intensiva è un'esperienza sicuramente molto dura e viene vissuta probabilmente in modo diverso da ognuno di noi in base al proprio carattere. Il messaggio che posso mandare è un messaggio di fiducia e di speranza, in quanto dobbiamo totalmente metterci nelle mani del personale sanitario che ha la formazione corretta per gestire soprattutto gli aspetti, oltre che quelli clinici, anche gli aspetti emotivi della persona e quindi psicologici, che sono, secondo me, forse per il paziente e la famiglia gli aspetti più importanti.
You are the spouse, you are the brother, the sister, the parents, the children of an ICU patient, you are a friend. All of you are family members. Of course, we are not going to have the same communication with any of you according to what's the relationship between you and the patient, but we are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
The team was so human and kind. They helped me psychologically every day. I was waiting for the call every day with impatient. So that period was really very hard for my family. The team of ICU became really my family. I felt them closer even than my parents. Every day someone from the team called me and informed me about the situation of my husband and the next steps to do. And I want to say that even if I was far from my husband, I have been always updated about his clinical situation. And when there were very important decisions to make, for example, like tracheostomy, they called me 4-5 times per day. So I want to say thank you. For me, it was a new experience, like for many other people. I have never faced ICU. So after this experience, I changed my life. I changed all points of view. It was a really very hard period, and I was about to lose my husband, but I have never lost hope, and I tried to be strong and rational. I remember my first visit in ICU very well, because it's impossible to forget. It was so emotional. After 64 days, finally, I could see my husband, touch his hands, see his eyes. It was really very difficult to live without him and without personal contact. I don't have enough words to say thank you to the doctors for that possibility that they permitted me to visit him in ICU. Thank you very much. I'd like to say to the future patients and their families that they should trust to the staff of ICU. They are left in the hands of professionals that work tirelessly with passion and love. They are always with the patients. The patients are the primary focus for them. They always gave the warm care and necessary treatment. They never leave alone patients. They are always with them and ready to help them in any moment. The patients are the primary focus for the staff. In the end, I want to say, no matter how ill the patient, don't give up hope.
Having a loved one in the ICU can be an extremely distressing experience. Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disorientated. So don't forget to take care of yourself. Sometimes you will need to take a break. You don't have to stay with the patient 24 hours a day, and you mustn't feel guilty if you do need to take that break. Don't forget that the ICU team will continue to care for the patient while you're not there, and they will always call you if there is a change in his or her condition.
My name is Silvia. I'm a critical care nurse. I work in an intensive care unit. My work is to assist the doctor and to help them to prepare the patient to get all the medicines and the treatments they need in the ICU. When the family first enters in the intensive care unit, I will receive them and welcome them and present them the room and the patient and explain the condition of the relative. I will be there to receive also their emotions, how they are feeling about it, and explain them what the patient is feeling at the moment, what we are going to give them for treatment. We will be there in any case to help them to go through these days in the intensive care unit and to perceive and communicate with the patient. We will be there to help him and assist him to the toilet, to the feeding, and to do anything that the patient will not be able to do. But moreover, we also will be there to see how is he feeling, if it's uncomfortable, if it's in pain, to learn to communicate with him all over the stay with all the equipment he will have. We will explain them the things that will happen to him and to his family, and to interact between the doctors and the patient.
The main role of a physiotherapist is the rehabilitation of the patient. With the term rehabilitation, we mean restore the previous situation that the patient had before his or her injury, his or her trauma. And so the patient could have again his or her previously autonomy in the best way it could be possible. A physiotherapist could work inside the intensive care unit, so it is a member of ICU team for all his or her working time, while in other countries the physiotherapist comes to ICU just only for the rehabilitation moment.
Hello, my name is Stefan Schaller. I'm an anesthesiologist and intensivist. As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients. My role is to coordinate the healthcare team to do the diagnosis and the treatment of the patient. To you, as a family members, I have to explain what is going on with your family member in the ICU. I explain to you what we are doing for diagnosis. I tell you the options for treatment and how to treat the patient. Very often, we have to discuss what are the wishes of your relatives, although he's not responsive. Therefore, we discuss together with you what is the best care we could provide for your relative. In the beginning of your ICU treatment, very commonly you are unresponsive. You will be examined by me or a colleague every day. We will make the diagnosis plan and the treatment plan. Later on, when you're waking up again, we are starting to talk with you about the treatment plan as well. While you are unresponsive, we try to discuss the care with your family, or we look at any documentation you provided, how the care should be provided for you.
As a social worker, I'm part of the ICU team. I regularly come on a daily basis to the ICU and talk with the professionals on issues with the families or with the patient. For example, when it's about communication or when there are conflicts, but also when the families have a request so that I can help them to overcome that issue. What I notice is that the families have a really difficult time. They are stressed about their loved one, but they also have, for example, issues for themselves. For example, they have questions, can I take my children into the ICU? Or how can I manage the homework? Or what can I do about financial problems? So I try to help them with that kind of issues. And sometimes they are also asking life questions, because, for example, why is this happening to me or to us? And what's the meaning of this, that he or she is going to have this critical illness? So I try to help them with this kind of issues. My relationship with the patient is to get him or her to learn him better. And I think it's very important to have the values, what is important for the patient, to have them bring into the care that we provide in the ICU. And I think that it is compassionate care, humanizing care, and that is combined with the highest technical and medical treatment that we provide. And in that way, we have excellent care that we can provide in the ICU. And I try to bring my expertise and to have the patient and his meanings and his opinions in front of it.
A special aspect in my daily practice is the communication with the patient and the communication with the families. Communication in ICU is very difficult because clinical situation is very complex and sometimes it's not so easy to explain to families. And in my opinion, the most important thing is to try to keep it very simple, not to spend a lot of technical words, but I just only try to explain the clinical status with simple words. It's very important to try to develop a relationship with the patient and try to keep it quiet, to tell him that the situation is under control. It's very important to maintain a patient calm and confident with the team, because very often the patients are very scared by the environment of the ICU. So it's very, very important to guarantee the comfort of the patient.
We work together as a single team with patients and families, and that's crucial for the recovery of our ICU patients.
Good afternoon, ladies and gentlemen. Welcome to this HASIC webinar that will be focused on the future of percutaneous tracheostomy in the ICU post-COVID. This is really an important matter and related to the changes that the COVID-19 has produced over our conventional use of tracheostomy. May be essential to make a sort of state of art regarding this issue. It's really a pleasure today having three very distinguished speakers. But before to start, I remind the audience that can ask questions during the various presentations by using the chat, which is inside the left shoulder, the right shoulder of the screen. The first speaker is a great pleasure because she is also a dear friend, Ishiria Mayatra, who is professor of intensive care at the Tata Memorial Hospital in Mumbai in India. She is really a very distinguished speaker. She's a president-elect for the 2022 of the Indian Society of Critical Care Medicine. She's a chair of the Intensive Care Committee of the World Federation of the Society of Anesthesiology, and she's really an expert in the field. She has also led some projects concerning the universal management of the airways, developing also the guidelines of the difficult airways. And ultimately, she has a multiple interest in research, focusing on hemodynamic monitoring besides airway management, respiratory failure, and sepsis. Sheila, it's your turn.
Thank you so much, Prof. Antonelli, for that very, very kind introduction. At the outset, I'd like to thank the European Society of Intensive Care Medicine for giving me this opportunity to speak at this meeting. It is indeed a great pleasure. I bring you greetings from the Tata Memorial Hospital in Mumbai. Before I start my presentation, I would like to declare that I have no conflict of interest for this talk. I will be speaking on airway management in during percutaneous tracheostomy. And I will be focusing on various aspects of specific to the airway management. Before I start with this, I'd just like to give you a little background. So when we talk about airway management in tracheostomy, first, what is tracheostomy? As we know, is a surgically created airway that keeps the which is kept open with a tracheostomy tube, which is inserted directly into the trachea through an incision taken in the neck. And you can do both an open surgical tracheostomy, or you can do a dilatational technique, which we call percutaneous technique. And this can be performed very quickly and safely at the bedside with the use of a modified Seldinger technique. And we all know that this approach is associated with fewer bleeding complications than the open tracheostomy. However, they are similar in long-term mortality. And I just like to say that, in this presentation, I'm going to talk about a stepwise approach to maintain upper airway patency and oxygenation during a percutaneous dilatation tracheostomy. I'll talk about various strategies to enhance patient safety during a percutaneous dilatation tracheostomy. I'll talk about various rescue strategies in the event of airway loss or failed procedure. And I'll also talk about, the post-procedure plan that we can initiate for these patients to maintain a safe airway. Now, I'm very happy that this topic has been allotted to me for the very reason that people focus too much on the procedure of percutaneous tracheostomy. And we know that this isn't without complications. And most of the complications occur when the airway is not managed. So the role of the airway manager and the airway management during percutaneous tracheostomy is very, very crucial. And this is something that's often not taken very seriously because the focus is largely on the procedure of performing percutaneous tracheostomy. And this is what I'd like to highlight in my presentation. So I'll come to the first part about anesthesia and positioning of the patient. Now, it's very important to remember that unlike a surgical tracheostomy, which can be performed in an awake patient after giving local anesthesia, a percutaneous tracheostomy is an elective procedure to be performed in a patient we've given full anesthesia, deeply sedated, and even neuromuscular blockade. And this is because you're not taking a cut on the trachea. This is a dilatational procedure. You don't want the patient to move or cough or buck even slightly, because this can cause trauma to the posterior tracheal wall and can lead to complications. So this is something very important to keep in mind when you're doing airway management. And to understand this, you need a very experienced airway manager, both in securing the airway as well as in delivering anesthesia, and also for rescue oxygenation of this patient. Of course, we take consent. We need to check the coagulation profile before doing any airway management, and cease enteral feeding, because we don't want aspiration when the airway is unsecured. The patient, as I mentioned, should be anesthetized and paralyzed with the airway completely secured during this procedure. So we're not talking about a percutaneous tracheostomy done in an emergency or a percutaneous tracheostomy done in an awake patient. This should be a patient under general anesthesia with neuromuscular blockade. And of course, because we're doing this procedure at this time, and there may be situations where there's airway loss, we need to ventilate this patient with 100% FiO2. Now, the position of the patient is very important, and you need to keep the patient with the neck extended, shoulders elevated, and the bed at about 30 degrees head up. And this, to avoid reduction in the venous pressure and for maximum exposure on the neck. So this all makes your airway management very easy. Now, ultrasound during the percutaneous tracheostomy. What is the role of ultrasound? Now, it's very useful. Ultrasound is like a stethoscope in the ICU today, and we can use it for a quick screening to identify the optimal needle position that we may use. It also enables us to measure the exact distance from the skin to the trachea, and also avoiding the any blood vessels that may be in your path. And this is especially useful when you have a patient who's having a difficult neck anatomy, or in whom the trachea is difficult to palpate and may not be easy to locate. So looking at the ultrasound during percutaneous tracheostomy, when you do a sagittal view, using the probe, you can visualize the thyroid cartilage, you can look at the cricoid, and you can look at the tracheal rings, and you can perfectly identify where you want to go. We usually go between the second and the third tracheal rings. And in addition to this, you can also do a transverse view, and here you can see the thyroid isthmus, you can see the tracheal ring, and then you can look for any vessels that are coming in this way. So this can be avoided. So it's extremely useful to use this, do a quick neck screening. Some people may also use this during the procedure. Use this, to monitor how your needle is going in, guide wire is doing it. But I must say that this is, this needs a very experienced operator with ultrasound to hold the probe and also be able to do this procedure. It is challenging and it needs a lot of experience. Even if you don't use it during the procedure, definitely for screening the neck, it's extremely useful. Now, I'll talk a bit about tracheal tube withdrawal, and I'll tell you this is the most crucial step during the percutaneous tracheostomy in terms of airway management. Before you start, it's good to do a nice oral and tracheal suction so you don't have too many secretions coming in your way. The tracheal tube should be withdrawn, and some people like to replace it with a supraglottic airway device. Now, this withdrawal is very important. Deflate the cuff, withdraw the tube. And why do we withdraw the tube? Because you don't want the needle or the guide wire or the dilator to go through the Murphy's eye. And this can lead in an absolutely, catastrophic situation if you haven't withdrawn the tube. And withdrawing the tube has a danger of losing the airway. So you have to be extremely careful during this stage when you do this. So you deflate the cuff, and how far do you withdraw it? You withdraw it just enough that the cuff is, at the vocal cords or just above the vocal cords. And then you note the marking at the level of the incisor. It's good to use a videolaryngoscope to do this procedure so you can, view this with your colleague. And then you need to hold the tube there and make sure it doesn't get displaced throughout the procedure. And this is extremely crucial. You don't want the tube to be too in and you don't want the tube to be too out. So conventional direct laryngoscopy or videolaryngoscopy may be used, but the view may be worsened when you do this kind of position for the tracheostomy. Now, some people prefer to remove the endotracheal tube and replace it with the supraglottic airway device. Now, what is the role of a supraglottic airway in this? Now, a supraglottic airway may be inserted to perform a percutaneous dilatation tracheostomy. For instance, you have a patient in whom you want to perform a tracheostomy. Now, this patient is awake. He's not a critically ill patient, but you want to do it by the percutaneous tracheostomy. You can't do it in this patient who's awake. You don't want to intubate him, so you can just anesthetize him and temporarily put in a supraglottic airway device and then perform the percutaneous dilatation technique. As I mentioned, you need to do this under general anesthesia. Or, as I mentioned, some people prefer to take out the tracheostomy tube and put a supraglottic airway device prior to doing this. But remember, this requires experience and a skilled operator and optimal positioning of the supraglottic airway device. So don't venture to do this unless you're familiar with the use of the supraglottic airway device. And if at all you use it, use a second generation supraglottic airway device, because this has a higher ceiling pressure and also one through which the bronchoscopy, endoscopy can be performed and, achieved. So that should be chosen, not just any supraglottic airway device. You don't want any seal, especially in critically ill patients. And the supraglottic airway device, the advantage is that it facilitates easy visualization visualization of the tracheal puncture with the bronchoscope, which may be a challenge with the tracheal tube, because if you haven't withdrawn the tracheal tube enough, sometimes you may not be able to visualize the puncture site easily, whereas this is not a problem with the suprachoroidal airway device. And remember, you may not be able to put the suprachoroidal airway device in all patients. They're not suitable, especially in those who have high airway pressures. So it's only in a select group that you may be able to put this. Now, the role of flexible bronchoscopy during the percutaneous tracheostomy is paramount, and how you use it is very important. Now, what is the role of this? Now, this enables the passage of the needle, guide wire, and dilator to be observed during the insertion. And this is extremely important. As you can see here, the person is viewing it through the bronchoscope and having a very nice view of what's going on. And you don't want the posterior tracheal wall to have, the guide wire or the needle going through this. And this enhances the safety of the procedure. And what's very, very important is the bronchoscope should remain within the tracheal tube. Otherwise, you can cause damage to the bronchoscope. You can have your needle and dilator going through the bronchoscope. So this is a word of caution about that. And also remember that it may not be possible to identify the level of the tracheal puncture unless you use either an SJ or the tracheal tube is withdrawn sufficiently. So this is very crucial during the airway management. But the most problem that you really face is that the ventilation may get compromised, because you may have some resistance, there might be some hypoventilation, and there might also be scope damage unless you handle it carefully. So this requires a lot of practice and also a lot of skill. I'll just show you a little video of how you could use flexible bronchoscopy during the procedure. Some people, you can see that lantern glow, and you can use it even to locate the tracheal rings. So the bronchoscopy may be used for this procedure. Some just use palpation, or they may use ultrasound. But throughout the procedure, you're doing it under vision. You're visualizing what's happening when the needle is going in, when the guide wire is going in, when the dilator is going in. So this is an enhanced safety, and you're sure that the posterior tracheal wall is not getting injured. It's useful to have a smaller size bronchoscope that you can use, so that there isn't much resistance. You can see the beautiful lantern glow that you see on the neck when the bronchoscope is inside. So throughout the entire procedure, and here you can see the dilator going in at all the steps. Now here you can see, as you're pushing the dilator inside, you can actually visualize the steps. So it gives you a very good view right till the tracheal tube is passed. Now, what is most important is the rescue oxygenation and ventilation. And this is the most crucial role of the airway operator. We have 3 tools in our armamentarium. One is mask ventilation, suprachoroidal airway device, and then we have the tracheal tube. And if any of these 3 devices fail, we have to immediately progress to do a neck rescue. So remember that whatever technique you choose, oxygenation, ventilation, and anesthesia must be maintained during a percutaneous tracheostomy. Now, remember, the airway device may get displaced. There might be inability to perform the procedure, or sometimes there can be very serious bleeding. So you should be ready to compress the bleeding, cover the site, and re-intubate the patient. So the role of the airway manager at the head end is absolutely crucial, because you have to be watching this. Your tube is partially out, and you should be ready to re-intubate this patient. And this can be especially challenging if it was a previously difficult intubation. And if mask ventilation or supraglottic ventilation fail, then you need to proceed to a neck rescue. If there is complete ventilation failure and you cannot intubate, cannot ventilate the procedure, even if your percutaneous tracheostomy procedure failed, you should immediately progress to do a neck rescue and do an emergency cricothyrotomy and oxygenate this patient. So this is the most crucial role of the airway operator. Most of the time, nothing like this happens, but if it happens, the airway manager should be ready to do this. Now, after the procedure, what's very important is that you should confirm the tracheal tube position using waveform capnography, 5 to 6 consistent waveforms with no decline, and make sure the tube is in the right place, even though bronchoscopically you have seen the tracheal rings. Very important to fix the tube. I'll come to this in a minute. Do a nice tracheal suction, and also follow it up with an X-ray chest. Make sure the tube is in the right position. There's no pneumothorax. You can also use lung ultrasound for this purpose, and make sure that there's airway pertinency at all times. Now, I want to tell you something about fixing the percutaneous tracheostomy. This is really, really important. Unlike a surgical tracheostomy where you're taking the incision on the trachea, what happens, this surgical tracheostomy matures in about 3 to 5 days, whereas a percutaneous tracheostomy, it's a dilatational technique. It takes up to 7 days. So recently dilated tissue, what happens is when the tube gets dislodged, the tissue can spring back into their original position. And as you can see here, it makes it very difficult to reinsert it. Okay, this is not so much the case with a surgical tracheostomy, and this you have to keep in mind. So make sure you fix it properly. Some people take sutures, or you can have the ready bands that are available, or the tape, but this is really important. A little about percutaneous tracheostomy in COVID-19 patients. We recently did a Delphi along with a group of international experts on acute respiratory failure. And this was published in March 2021 in Critical Care. And we looked at expert consensus statements for the management of COVID-19 in acute respiratory failure. I was very proud to lead this study along with Prashant Nasa, and Professor Antonelli is also one of the experts on this project. And we came up with 20 expert clinical practice statements. And I'd just like to tell you what the consensus was among the experts regarding tracheostomy. The timing of the tracheostomy to facilitate weaning for invasive mechanical ventilation should be the same as in non-COVID patients. And they said percutaneous tracheostomy with or without guidance of ultrasound or bronchoscopy may be preferred among other techniques. So the consensus was that over a surgical tracheostomy, a percutaneous tracheostomy was what the experts preferred. And definitely if you're doing it in COVID-19 patients, you need to wear full personal protective equipment. You need a highly specialized team. You need to limit the number of operators, and you need to have a very quick job so you have less exposure to the aerosol, and complete neuromuscular paralysis to reduce the aerosol generation. I'd just like to conclude by saying that percutaneous dilatation procedure, remember, it's an elective procedure. Hence, be very careful that, how you select the patient, the preparation and the planning. This is very essential. It's not something you do in an emergency that you can have an excuse that all the tools I needed were not there, all the rescue apparatus was not there in my armamentarium. The role of the airway manager is crucial, as I've mentioned, to maintain oxygenation, ventilation, and airway rescue if required. The use of airway ultrasound and bronchoscopy can enhance patient safety. And most importantly, post-procedure, capnography should be used to confirm the correct position. Proper fixation of the tube is paramount. Follow it up with an X-ray chest and also a lung ultrasound if you're familiar with doing it, and maintain airway patency. And these are paramount even post-procedure. I just leave you with this book that was recently published by Tim Cook and Professor Michael. And I was very fortunate to write a chapter on the patient with a tracheostomy with Professor Bendon McGrath, where we described all the important aspects of airway management in a patient with tracheostomy. And I also urge you to read this recent review that was published less than a year back in the NEJM, which describes all aspects of airway management during percutaneous tracheostomy. Wherever you are listening to me, I hope you take care and stay safe. Thank you very much for your attention.
Thank you very much, Sheila, for this very detailed state of art concerning the major issue of the tracheostomies. Thank you very much indeed. The following speaker will be Professor Grasselli. Professor Grasselli is a full professor in anesthesia and intensive care medicine at the University of Milan. And he is at present the medical director of the ICU in the Ospedale Maggiore Policlinico in Milan. And he's also one of the coordinators of the ECMO network we have in Italy, and now is also the regional coordinator for the COVID-19 pandemia in the north of Italy. He used to be the Italian representative at the Council of the European Society of Intensive Care Medicine, and he's also chairing at present the intensive care section of the Italian Society of Anesthesia, Resuscitation, Intensive Care Medicine, and Pain Therapy. I would say that he will touch a very important issue concerning the selection and the timing of the tracheostomy, just focusing on which patient and when. Giacomo, the stall is yours.
Oh, thanks Massimo, and thanks to the ESICM leadership for this invitation. So I'm Giacomo Grasselli from Italy, and these are my conflicts of interest. And as you can see, none of these is related with the content of this presentation. So this slide is taken from the Tobin book, which, as you know, is a very well-known book on mechanical ventilation. And this describes, I would say, very well advantages, disadvantages, and the current indications for tracheostomy. And basically, there are four main indications: maintenance of airway patency, provision of airway access for suctioning, for example, and prevention or limitation of aspiration in patients who are unable to protect the airways and to manage secretions, and of course, management of patients who who require long-term mechanical ventilation. And this is because tracheostomy provides decreased airway resistance, facilitates weaning from the ventilator, and enhance oral nutrition and oral hygiene, and improves patient comfort, patient mobility, and reduces the sedation needs. So tracheostomy is a very important procedure in the ICU, and as we've heard by Sheila, it must be performed with a lot of careful and patient management and patient monitoring. Going to sort of epidemiology of tracheostomy, these are data from a secondary analysis of the Lung Safe study. As you know, the Lung Safe study is a large observational cohort study that included almost 3,000 patients with ARDS. And as you can see here, among the patients who were initially invasively ventilated, so managed with invasive ventilation, about 15% underwent tracheostomy during the ICU stay. In this secondary analysis, there was also a comparison between patients undergoing early or late tracheostomy, and the threshold for early or late was 7 days from ICU admission. And as you can see here from this table, but we will see this in more details later, apparently early tracheostomy was associated with some improvement of a number of clinical outcomes. And also, the data from this study seem to indicate that patients who were tracheostomized during the ICU stay had an improved probability of survival. But I have to warn you, I mean, these data do not compare the patients of the same severity. We do not have enough data to draw any conclusion on the effect of tracheostomy on the patient survival. This is another large study from a US database. You see there, this study describes the trend in time of the use of tracheostomy. And as you can see, we see an increase in the number of tracheostomy procedures from 1998 to 2012, both in non-surgical and especially in surgical patients, and apparently an improvement in the outcomes over the years. But again, also in this case, we cannot say that the improvement in the outcomes is related to the increased use of tracheostomy. Then if we go to the issue of the timing of tracheostomy, if you put timing tracheostomy in PubMed, as you can see, you obtain almost 700 papers from 1972 to now. And as you can see, the number of papers published on this issue has continuously increased over the years, with a major improvement in the last 2 years, thanks to COVID-19. So there are several papers published on the timing of tracheostomy. I'm just showing you these two papers in chest for, let's say, historical reasons, because these are the two first papers maybe comparing different timing for tracheostomy. And as you can see on the left side of the slide, in this paper, they compare the timing of tracheostomy and the percentage of patients undergoing tracheostomy according to different diagnoses. But as you can see here, very small numbers of patients. And on the right side, this other paper published in chest in 1991, which is probably the first paper to suggest that early tracheostomy may be associated with improved patient outcome in patients with acute respiratory failure. Then going to the years 2000, this is a small but interesting paper because basically this paper subdivided patients who were scheduled for weaning from mechanical ventilation and compared patients who were tracheostomized prior to the start of weaning or to patients who underwent selective tracheostomy during the weaning and during the weaning process. And again, you can see here that patients treated with early tracheostomy seem to have an improved probability of liberation from mechanical ventilation. And also the timing of the procedure, together with the PF ratio before the procedure and the occurrence of ventilator-associated pneumonia after the procedure, is one of the major factors associated with an increased probability of weaning from the mechanical ventilation. Then we go to randomized study. This is the TRACMAN study published in JAMA in 2013 on more than 900 patients. These patients were undergoing mechanical ventilation and they were recruited if they were judged as likely to require at least 7 more days of mechanical ventilation after the first 4 days from ICU admission, and then they were randomized to early tracheostomy that was performed within the first 4 days from admission versus late tracheostomy that was performed after the 10th day. So you can see here that in the group of early tracheostomy, most of the patients were tracheostomized on day 3, while in the group of late tracheostomy, most of the patients were tracheostomized on day 10, and a good proportion of the patients assigned to the late tracheostomy group eventually did not actually undergo tracheostomy, but this study failed to show any advantage in survival for early tracheostomy compared to late tracheostomy, and maybe a slight advantage in the need for sedation in patients undergoing early tracheostomy. This is the second important randomized study published in JAMA in 2010, and Massimo Antonelli is one of the authors of this paper. And this paper aims at identify an association between the timing of tracheostomy and the risk of ventilator-associated pneumonia. So 400 patients under mechanical ventilation with a certain disease severity randomized to early tracheostomy, defined as a procedure performed after 6 to 8 days from intubation, compared to late tracheostomy, which was defined as a procedure performed after basically 2 weeks from intubation. In the table, you can see the difference in the complications between early and late tracheostomy, and in the Kaplan-Meier curve, you can see a non-significant, but I would say a quite clear trend towards a reduced risk of ventilator-associated pneumonia in patients undergoing early tracheostomy. Then, of course, we have systematic reviews and meta-analysis. This was published in the BMJ, and it shows that early tracheostomy seems associated with an improvement in the duration of ventilation and in the ICU length of stay, without differences in mortality and risk of VAP. And there is also a Cochrane review that does not show any difference in mortality at 28, 30, and 60 days, and maybe a trend towards improved mortality at 1 year, but this comes from only 2 studies. So it's very important to analyze long-term outcomes after tracheostomy. This is one paper that it's entitled long-term outcome, but basically compares the risk of complications between surgical and percutaneous tracheostomy. And as Sheila was saying, percutaneous tracheostomy is associated with the reduced rate of tracheal stenosis, major bleeding, and wound infection. While this is a very interesting paper published in Critical Care Medicine 2 years ago, and this compares 1-year outcomes following tracheostomy for acute respiratory failure it's a retrospective study, but it's on a very large cohort of patients, more than 8,000 patients, and the outcomes analyzed were long-term survival and healthcare resource use. And it's very interesting to see that patients who underwent tracheostomy during the ICU stay had a quite high one-year mortality. You see that hospital mortality in these patients were 19%, but increased up to 46% at 1 year. And this difference was even more important for patients aged more than 65 years of age. So patients who undergo tracheostomy during the ICU stay for acute respiratory failure seem to have a significant increase in one-year mortality. Then we can analyze some special patient population. For example, patients with acute stroke, and this is a table taken from the set point randomized pilot study that indicates that early tracheostomy in patients with stroke invasively ventilated is associated with reduced sedation need. And based on the results of this pilot study, then a new larger study, which is called set point 2, is currently ongoing in the population of patients with stroke. We know that early tracheostomy may be useful in patients with myasthenic crisis and in general in patients with neuromuscular disorders and acute and respiratory failure associated with neuromuscular failure. And in patients with traumatic brain injury, this is the large center TBI study published in Intensive Care Medicine very recently on more than 1,000 patients. This study shows that patients undergoing early tracheostomy, I mean, within 7 days from ICU admission, had improved neurological outcome and reduced length of stay. In trauma patients without TBI, also other studies have been published, and I'm just showing you this one that proposes a score, which is called the TRAC score, that takes into account this variable to foresee, to predict the need for tracheostomy during the ICU stay for patients with major trauma without traumatic brain injury. What about ECMO? ECMO, tracheostomy during ECMO is feasible. There are a number of studies that have been published, and most of these studies show that tracheostomy during ECMO is feasible. Percutaneous tracheostomy is usually performed. Clearly, the procedure must be performed by experienced physicians in experienced centers, and there are basically no major impact on complications from the procedure and from the usually limited reduction or stop of heparin infusion peri-procedure. What about COVID-19? Sheila was saying something about this. This is a statement from an expert opinion that suggests that tracheostomy in patients with COVID-19 should follow basically the same indications as in other patients, and it may be indicated in patients expected to require prolonged mechanical ventilation, which, as you know, are a high proportion of patients with COVID-19. At present, no specific timing for tracheostomy can be recommended. Of course, it's very important that during the procedure, the operators wear enhanced personal protective equipment. And also, always regarding COVID-19, there is a very nice paper published in the Lancet that shows that, for example, this time window between 16 and 30 days from ICU admission seems the more favorable one, at least the one associated with the reduced infectious risk. And this paper reviews also the factors that suggest in some way that favor early tracheostomy and the factors that favor delayed tracheostomy. So in conclusion, we know that percutaneous tracheostomy is safe and feasible. The indications to tracheostomy have not changed over the years. While the timing remains debated, there are studies and data showing that early procedures, so within 10 days from ICU admission, might be associated with reduced ICU length of stay and the duration of mechanical ventilation, while the effect on survival remains uncertain. Clearly, recognizing the patients who need tracheostomy, especially those who will need prolonged mechanical ventilation, remains a challenge. And we can also say that tracheostomy can be safely procedure even in special conditions like ECMO and patients with COVID-19. So with this, I thank you very much for the attention, and I'll be happy to take your question at the end of the session. Thanks.
Thank you, Giacomo. Thank you very much for the huge number of information you have given during your presentation. And I'm sure that there will be a number of interesting questions because some of the issues are still debating and open. The following speaker is Abhinav Agrawal. He is a Director of Interventional Pneumology and Bronchoscopy at the Northwell Health in New York, and is also appointed as Assistant Professor of Medicine and Assistant Professor of Cardiovascular and Thoracic Surgery at the Donald and Barbara Zucker School of Medicine at Hofstra and always at Northwell. He is a really distinguished educator for chest, and he was awarded by the American College of Chest Physicians in the last 3 years. And he has he's the author of numerous and original articles, review articles. His primary research interests include the benign and malignant pleural disease, benign and malignant central airways obstruction, and all the aspects that are related to the trachea and the airways. His topic today will be the weaning with a tracheostomy, and he will focus even more on the long-term outcome. Abhinav, the podium is yours.
Thank you so much, Massimo, and thank you, everybody. I wanted to thank the European Society of Intensive Care Medicine for the invitation to present. I'm going to talk about weaning with tracheostomy and outcomes related to the same. I have no conflicts of interest relevant to the talk itself. So just an overview of what we're going to talk about. Dr. Miatra and Dr. Grasselli did a great job in summarizing basically how to manage the airway and how to and when to perform a tracheostomy. What we are going to talk about is once the patient is doing better, what are the indications and contraindications for tracheostomy decannulation? How do you wean the patient and describe the weaning process in detail? And then discuss some of the outcomes that have already been touched upon, and also talk about some of the long-term and short-term complications that can occur, especially with percutaneous tracheostomy and how they compare to surgical tracheostomy overall. So talking about tracheostomy weaning, of course, the first important step with any patient in the intensive care unit is ventilator weaning. And as we all do, but what we need to continue, especially with the COVID-19 pandemic, is daily assessment for weaning the ventilator and continuing pressure support trials. And especially if your patient is already has a tracheostomy, that becomes slightly easier. And then we also want to decrease the sedation as much as possible. And this has been a challenge with our patients with COVID-19, sometimes where they require a lot of sedation. It is also important to make sure that in case pain medications are needed, that we try to use non-sedative, non-opioid pain medications as much as possible so that we can, facilitate weaning. And then we start these patients on pressure support or a T-tube, depending upon institutional practices. We start with a pressure support of 10, ideally sometimes 15, depending on how sick the patient is, with a PEEP of 5, and then carefully monitor the patient. And if the patient is tolerating that well, decrease this while monitoring for both comfort, but tachypnea and tachycardia, and also to make sure that there is hemodynamic stability. What our goal is to reach a pressure support of 5/5 if you're using pressure support ventilation. And then once you're at that goal, be that in the intensive care unit, or sometimes we do this in the respiratory care unit in the United States, we can proceed towards tracheostomy weaning and assessment for decannulation in a stepwise fashion. Once we reach that point where we think that the patient may be ready, it is important that we ask ourselves some questions. The questions which may inhibit or prohibit proceeding towards decannulation. And some of these questions are, has the underlying reason of the tracheostomy resolved, be that maybe the pandemic right now, or even any other cause of respiratory failure, and can the patient protect his own airway? We want to make sure that the patient is oxygenating okay, with ideally oxygen therapy less than 40% FiO2, make sure that the patient is hemodynamically stable, that while we are focused on decannulation, that the overall state of the patient is stable. and also make sure that they can cough and clear their secretions, because the tracheostomy can facilitate suctioning secretions frequently, and therefore we want to make sure that these patients are able to clear their secretions before we think about weaning off the ventilator and then especially weaning the tracheostomy tube itself. We also want to see if these patients have any active signs of superimposed bronchopulmonary infections or excessive pulmonary secretions. We want to also see if they have non-respiratory disease. They may have neuromuscular disease, ALS, other underlying conditions which may preclude weaning of a tracheostomy. So we want to make sure that we consider and review their history thoroughly, especially if this patient is presenting not as a continuous hospital stay, but maybe was some other hospital and now is presenting to you for weaning of the tracheostomy tube itself. We also want to make sure that there is no imminent or forthcoming procedure that will require an anesthetic agent, because these patients then will require a secure airway again, and we then maybe want to hold off a few days till the procedure is completed. We want to set up a multidisciplinary program with our ENT colleagues, with our respiratory therapists, with our nurses, with our speech and therapy, swallow therapy staff, to make sure that the environment is suitable for tracheostomy weaning and that people are experienced in case there are issues. And then we also want to make sure from the patient perspective that he's able to, or she's able to sit in a chair or in a bed, sit up, and able to stay awake so that they can maintain the patency of the airway. We also want to make sure that there's no obvious contraindications. If the patient is not able to tolerate a cough down or deflation, if there is a sign of airway obstruction, either subglottic or below, like a tracheal stenosis, if the patient is medically unstable or there's some sort of cognitive impairment, if there is some sort of narrowing of the larynx in the trachea, and sometimes we may need to assess that with either a tracheoscopy through the tracheostomy itself, or in cases of subglottic stenosis, a laryngoscopy plus minus the tracheoscopy, to make sure that we are not dealing with a stenosis that may preclude a weaning of the tracheostomy. Or if the patient has advanced pulmonary disease where they're not able to tolerate decannulation, and one of the reasons of placing the tracheostomy was this advanced pulmonary disease. And then we also want to assess if these patients are prone to recurrent aspiration pneumonia or recurrent ICU admissions or hospital admissions, because in that case, weaning the tracheostomy may not be conducive and may actually lead to increased burden for this patient in terms of the hospitalization. What are the stages of weaning? So once we know that the patient is okay for decannulation, the stages of weaning are as follows. The first step is cuff deflation. So what you want to do here is you want to deflate the cuff and make sure that the air can move from below the cuff itself through the top of the mouth. And the patient is, in this case, is required to manage his or her own secretions, because it removes the protection from aspiration from the larynx and the pharynx itself. And we want to make sure before we proceed with cuff deflation that we suction the oropharynx thoroughly and the tracheostomy to remove any secretions to give the patient the best chance. And if sometimes we are not rapidly progressing towards the next step in decannulation, what we may want to do is to switch to a cuffless tracheostomy if the patient is able to tolerate a deflated cough for a prolonged period. Once that is done, the next step is a finger occlusion. So you can see here that the patient, basically the patient himself, if, depending upon his neurological status and his functional status, is able to put his finger on top of the tracheostomy tube. Now what we are doing is basically allowing that airflow around the tracheostomy tube so that the air can move above or bound into the upper airway. And if the patient does not have stridor or respiratory distress, then we could proceed with the next steps of weaning. We want to make sure that the patient is able to do that. We can also test the patient's voice at that point. If there is stridor or respiratory distress or absent breath sounds when that happens, or the patient is in respiratory distress, then again, it may warrant a tracheoscopy or a laryngoscopy or a combination of both to make sure that we're not dealing with some sort of stenosis. Another step is the one-way speaking valve. So what you're seeing here is we insert a one-way speaking valve, and what it does is once the cuff is deflated or you have a cuffless tube, the speaking valve is placed over the opening of the tracheostomy tube. What it does is it allows inspiration to the valve itself, but it closes on expiration. So the air actually flows from the mouth and the larynx and the pharynx, and therefore it'll give us an idea if the patient is able to maintain that airflow. And again, the length of the speaking time, the length of the time the speaking valve is tolerated will vary from patient to patient. But what we want to do is try to build up that tolerance, but be careful of, in the initial stages, not leaving the speaking valve overnight, because it can get clogged with secretions, and we don't want to run into a catastrophe, especially when there are less providers available. So we want to make sure that it's taken off at bedtime until we are sure that the patient can be capped. The next step is the CAD, more commonly known in the US as the red cap, but the decannulation cap is basically in a patient who has a deflated cuff, and we want to make sure that the cuff is completely deflated or a cuffless tube. This is the final step in the weaning process where the tracheostomy tube is blocked off, and we are basically stimulating that the patient does not have a tracheostomy. They're using their mouth and nose for inspiration and expiration or exhalation. And in that case, if the patient can tolerate 4 hours of the capping, or sometimes, depending upon how tenuous the patient is, you may want to do sometimes up to 24 or 1 to 2 days of capping trials. And if the patient is able to tolerate that, then you can proceed towards the next step of decannulation. So again, what we want to do is make sure that the patient can at least tolerate a cuff down or a cuffless tube for 24 hours, can tolerate a speaking valve for 12 hours, and a decannulation cap at least for 4 hours. And we want to make sure that the multidisciplinary team, the people that have placed the tracheostomy, the patient himself, the nurses, the speech therapists, all are in agreement with the decannulation, and then proceed towards the next step. So that was a brief summary of what weaning process entails. I want to quickly discuss some outcomes. And Dr. Grasselli did a great job of talking about timing and how it relates to the outcome. And this is a recent pro-con published in Chest, which is very interesting, I thought, by some of my colleagues, where they talk about what are the possible benefits of early tracheostomy, especially in COVID-19 patients. And you can see here that it's a vicious cycle where one problem leads to another. But if we can try to liberate the patients earlier, it can lead to lower sedation requirement, early mobilization, participation in physical rehabilitation, cognitive rehabilitation, neurological improvements, and making the patient feel more human. So I think that is something that is an important factor. What it is important to know that is, while that is great theoretically, it is not translated into mortality or morbidity benefit overall. So what we do know is that in some of the recent studies, some of which Dr. Grasselli quoted, is that in patients with early tracheostomy, it did demonstrate fewer days on the ventilator and a trend to decannulation, but the timing is still controversial, and the decision should be based upon the clinical course. If a patient has a multi-organ failure and you feel that the patient either has a poor overall outcome or is able to come off the ventilator pretty quickly, then you may not want to proceed with the tracheostomy because it does have its own burden. While on the other hand, if you feel that the patient is going to require prolonged ventilation, then early tracheostomy, which is defined here as less than 14 days, can be considered based upon limited evidence that we have currently. We also want to assess if in terms of percutaneous tracheostomy versus surgical tracheostomy. So you can see that in the recent study that was published by Mahmood et al. In Annals of Surgery, there was that percutaneous tracheostomy led to increased number of decreased ventilator days, decreased ICU length of stay, and shorter hospital stay compared to open tracheostomy. But this was not demonstrated in another study which was published a couple of months before by Long et al. In Annals of Thoracic Surgery. So what I could say is that with summary of current data, it favors percutaneous tracheostomy both from the exposure perspective as a first-line approach in the COVID-19 pandemic, but overall in terms of short and long-term complications, as we'll talk briefly, with open tracheostomy reserved for patients who have anatomical contraindications or in centers with a lack of expertise. So just briefly, what are the short-term complications? With perioperative complications, minor and major bleeding, postoperative granulation tissue, and postoperative infection. And this was a large Cochrane database review that compared actually surgical versus percutaneous tracheostomy and demonstrated that while there may be a trend of more short-term complications in one of the techniques, that overall there was no difference in the complications, with some other studies actually showing that the short-term complications rate are actually lesser with percutaneous tracheostomy, especially the decreased risk of stomal infection. And again, this was shown by a meta-analysis, as was demonstrated earlier by Higgins et al., which demonstrated a short or lesser trend of complications with PDT itself. What about long-term complications? Unfortunately, we have limited data on this with a few studies, and the studies of not so high quality, but at least we could try to summarize what it shows. So what are the long-term complications? And as an interventional pulmonologist, a critical care pulmonologist, it's important to be cognizant of the fact, because we are seeing an increased number of tracheostomy performed because of the pandemic and patients with respiratory failure. And a few years down the line, we want to be careful and monitor these patients for long-term complications. So what are the commonest complications? Tracheal stenosis, tracheonominate fistula, which could be short-term or long-term, tracheoesophageal fistula, sometimes tracheocutaneous fistula after decannulation, where the fistula doesn't close, swallowing and disorders and voice complaints. A few words about post-tracheostomy tracheal stenosis. It is the abnormal narrowing of the lumen from fibrosis or granulation tissue that can happen after PDT or surgical tracheostomy. And while the real incidence is unknown, approximately 3 to 12% patients develop significant stenosis that require intervention. And what you will see is these patients will present with failure to wean off the ventilator with high peak pressures or difficulty passing the suction catheter if it is below the tracheostomy tube, or sometimes signs of upper airway obstruction of dyspnea and stridor if it's subclavic stenosis. And it can occur due to either granulation tissue formation or overinflation of the cuff with focal ischemia, or sometimes damage to the cartilage or what we call the frame shape or A-shaped deformity. So what should we do? Avoid overinflating the tracheostomy cuff and balloon with the pressures below 25 centimeters of water. And as Dr. Mayatra mentioned, careful visualization of bronchoscopy during the percutaneous tracheostomy to avoid both cartilage injury and fracture and the location itself. And what should we be doing in management? We should be using a group approach, a multidisciplinary approach with ENT colleagues, interventional pulmonologists, thoracic surgeons. And if these patients have complex stenosis, a surgical approach is preferred with resection and end-to-end anastomosis, versus if these patients either have a simple stenosis or are not a surgical candidate, doing a rigid or flexible bronchoscopy with incision dilation, local therapy can be used, or sometimes they will require a stent or a T-tube placement. Another dreaded but complication, is extremely rare, is a tracheoinnominate fistula. Most patients will present with self-limiting bleeding in the first 1 to 6 weeks post-tracheostomy, known as the sentinel bleeds. If your patient, you're seeing that on your patients in the floor in the wards, or sometimes when they go home and come back, you want to be careful because these patients will present with sudden massive hemoptysis several hours later, and this can happen with the ischemic necrosis from the overinflated cuff, or sometimes a low placement of the tracheostomy tube below the third tracheal ring, or a high riding innominate artery. So we have the ability to do a bronchoscopy, and this should be used to avoid placing the tracheostomy below the third tracheal ring. And as Dr. Mayatra mentioned, we at our center routinely ultrasound our patients to pre-screen patients undergoing percutaneous tracheostomy, especially to avoid a high riding innominate, because that would be absolute contraindication to performing a percutaneous tracheostomy, in our opinion. If this does happen, the management is emergent and surgical with an extremely high mortality rate. So just a couple of lines about percutaneous versus open tracheostomy. The rate of tracheal stenosis, again, this is a limited data zone. There are only 3 studies comparing this in the long run, and with several limitations to each of them. But more recent study demonstrated that the rate of tracheal stenosis is comparable with a trend towards lesser tracheal stenosis with percutaneous dilation tracheostomy. But the important part is it should be done with centers of expertise with careful monitoring of the tracheal rings. There is no major difference in terms of swallowing disorders, voice complaints, or scarring. And then again, airway complication rates, you have to remember, can be underreported, as the patients may only present to the hospital where they become significantly symptomatic. And we know that that only happens when the stenosis tends to exceed like 50 to 60%, that the patient tends to get symptomatic. What we need to do as a group, especially in the pandemic, now that we have more patients and we have already learned so much collaboration, is to perform larger studies, registry-based, randomized studies, if possible, to overcome these limitations, and also avoid the possibility of selection bias when we assess these patients retrospectively. And then important is patient selection to avoid both short-term and long-term complication. And this was, again, as we say, prevention is better than cure. As Dr. Mayatra mentioned, we want to be very careful in the pre-procedural standpoint. We want to be careful in the procedural standpoint, make sure that we are prepared to deal with complications, and that we use the bronchoscope, we use the ultrasound, we use all these fancy tools that we have to our disposal for our patient safety. And then we follow these patients very closely to make sure that there are no complications. So in summary, again, for weaning, assess the patient if they can be weaned off the ventilator, evaluate if the patient is ready for a tracheostomy decannulation, make sure there are no obvious contraindications. And then in terms of outcomes, early tracheostomy may reduce some of the measures such as ventilator, ICU, and hospital length of stay, but it's still to show a difference in terms of overall morbidity and mortality, and therefore more studies are needed. It is important to monitor for these complications and approach them in a multi-D fashion, and that there is no major differences in the immediate postoperative or long-term complications between PTT and open tracheostomy, but there are more studies needed to assess and make sure that we can do a true comparison. Thank you, and I'm happy to take any questions along with other panelists.
Thank you very much, Abhinav. And I warmly thank all the 3 speakers for their excellent performance. Now it's time for the questions. We received some questions from the audience, and I would like just to start with Sheila. The first question that has been posed is, what do you think about the role of tube exchanger during the withdrawal of the endotracheal tube? And I also let you know another questions that is in part covered by Abhinav. It is in clinical settings, delayed bleeding sometimes will occur in patients receiving percutaneous tracheostomy. but difficult to detect within the short period of post-tracheostomy. And there suggestions about how to avoid it? So.
Right. So thank you very much for these questions. So regarding the tube exchanger, now the tube exchanger is usually used when there is a, the patient already had a difficult airway. So the tube is in situ, and it would be used if you want to use a supraglottic airway device, exchange it for this. So in this kind of setting, it has utility. But when you're doing a percutaneous tracheostomy, you already have a definitive airway inside. So essentially, the tube exchanger will not have a role if you have a loss of airway. And there's no role for keeping the tube exchanger in place while you're withdrawing the tube. That has not been recommended. It'll further increase the resistance and you won't be able to use your bronchoscope. So only in the setting where I want to change my tube to use a supraglottic airway device, I would consider doing this. Now, regarding the bleeding, most of the bleeding happens peri-procedural at the time of the procedure. And even when this bleeding occurs, it's usually self-limiting because this is a dilatational technique, unlike the surgical technique where you make a cut. So once you put a tube in, usually this bleeding settles. But of course, you have to have your tracheostomy kit, you have to have your arterial forceps and catch the bleeder and take a tie if required. But nevertheless, like any other tracheostomy, you have to monitor for bleeding complications that may occur, and the site of the insertion, the condition of the patient, the hemodynamics, as well as the around the tracheostomy, whether there's any hematoma or so. It needs to be monitored on a daily basis to watch for any late bleeding complications.
Thank you very much indeed. Giacomo, this is for you because a couple of people from the audience asked two questions. The first is what do you think may be the main factor for the decision for an early tracheostomy? This is the first question. And the second regards mainly the TBI patients. And our colleague is asking if do you think that data from centers that perform or treat TBI may have some confounders in delivering their data. For example, being able to do a tracheostomy before 7 days may be related also to the fact that the patient is less sick. And for these reasons, there is a delay. So these are the two questions for you.
Okay. So thank you for the questions. Well, regarding the first question, which is the optimal timing or the selection of the patients who can be candidate to early tracheostomy, well, clearly the idea that the main challenge is to identify those patients who would probably need the prolonged mechanical ventilation, and then once you have an idea that the patient will need prolonged mechanical ventilation, then performing early or late tracheostomy is more, how can I say, personal practice rather than supported by evidence. I mean, there are studies showing that early tracheostomy may be associated with reduced duration of mechanical ventilation and reduced ICU length of stay. But as Abhinav was saying, we probably need more studies and more solid evidence. And so I would say that you may consider early tracheostomy in patients who are expected to stay for prolonged periods on the ventilator and who may have, for example, major problems with sedation, or who are probably expected to have problems of weaning due to increased airway resistance, for example. And as Sheila was saying, this is very important, percutaneous tracheostomy and tracheostomy, except for very special situations, is an elective procedure. So I would not perform a tracheostomy early in unstable patients or in patients who have excessive compromise of gas exchange or hemodynamic instability. So the timing of tracheostomy also depends on the general condition of the patient. Regarding the second question, well, I'm not an expert of neurocritical care, and I did not participate to the center TBI studies. Certainly, the timing of tracheostomy in patients with TBI is may be affected by the severity of the patient. I'm not sure that it's only less severe patients, or maybe it's more severe patients who are expected to stay with a reduced state of consciousness for a prolonged period of time. For those patients, I think that tracheostomy may be particularly indicated. For example, because of the reduced sedation need, which is important in these patients, but again, also in this particular patient population, we do not have definitive evidence that early tracheostomy is a certain improvement compared to late tracheostomy.
There are a number of technical issues that the audience is just posing, but I want to ask you, make a personal comments to Abhinav. I noticed that one of the things that you have recommended is just to leave on the valve for at least 12 hours, and after that you may judge the patient ready for being decannulated. I can tell you that often this is an attitude very open, but a lot of pneumologists, at least at my sites, are very conservative. They do prefer to insist in trying winning, and according to one of the questions that has been asked, at least using downsizing the size of the tracheal cannula. I would like to know your opinion on these issues.
Oh, absolutely. So, I mean, it is important. So it really depends upon what you start with. Our preference here at the United States or our institution is we start with a size 6 tracheostomy tube, unlike other centers which are usually start with a size 8. So if you have a size 8 tracheostomy tube, then definitely once the patient tolerates the deflation of the cuff, you want to make sure that you can downsize so you have enough lumen available for the patient to tolerate a speaking valve or a cap, or even sometimes, depending upon the patient, a size 4 tracheostomy tube. So definitely, if you already have a size 6 tracheostomy tube and the patient is able to tolerate a speaking valve and tolerate a capping, then it depends upon the comfort and the expertise available at the institution. So we are lucky enough that we are staffed 24/7 in the respiratory unit. If we are doing a decannulation for a patient that has, luckily shown rapid recovery, then we'll proceed with those shorter numbers. But of course, if somebody has a chronic tracheostomy for other reasons, then we may be more conservative. So that, of course, comes along with depending upon the etiology and making sure that you know why your patient has a tracheostomy and what their underlying cardiopulmonary, especially their respiratory status is, before making those decisions. But those are the minimum numbers that you would take. Of course, the upper limit is depending upon both your comfort and your expertise available.
No question about it. Thank you very much. I guess that an interesting question regards the COVID-19 patients. Apart from my point of view, we should at least stress the various steps during which you may, if you are not careful enough, you may contaminate the environment, and then the protection and the attention should be maximal on part of the personnel. But saying that, one of the objection, or at least a question made by the audience, is if performing an early tracheostomy in a COVID-19 patient may render more tricky the proning the patient, and then maybe for these reasons could be preferable postponing the tracheostomy in these patients. What do you think?
If I can make a comment, in COVID-19, besides the infectious risk, there are several challenges. One is that many of these patients need anticoagulation, or at least an enhanced dose of antithrombotic prophylaxis. And so this is another issue that may make tracheostomy in general more challenging. We are used to prone patients with tracheostomy, but it's not as simple as proning patients with an endotracheal tube. So you can do it provided you are in a center with expertise and you have enough people to take care of the patient. And also for COVID-19, keep in mind the issue of anticoagulation, which may be also important.
Prof. Antonelli, if I may just add a comment to this. Yeah. Prof. Grafficelli talked about the timing of the tracheostomy. I just wanted to add a comment. Irrespective of the number of days, a very important aspect to consider is what is the FiO2 and the PEEP that the patient is on. And this is from the airway standpoint, because the moment you withdraw the tube and, there is this exchange of airway, the patients de-recruit. And you can have, precipitous fall in saturation and a real catastrophic situation. So, proning or not proning, if these, you have to be very sure that they are not on high FiO2 and the PEEP requirements are not much. You can always defer and do this later, irrespective of the number of days after tracheal intubation.
Okay. Abhinav, do you want to comment?
No, absolutely. No, I agree. I mean, those are all challenges that we have faced over the last year and a half. But it is important to remember, again, that the FiO2 should be tolerable. Again, sometimes in the ECMO patients, we have that benefit of being able to do that, especially because we know that they will need a prolonged weaning process, especially if they're on VV ECMO. So that may be a subgroup where we can stop anticoagulation. We have also faced issues with local bleeding. But as Sheila mentioned, with PDT, the ability to control local bleeding is pretty good with the tamponade technique that we use, and that major bleeding is very low. And as long as you're screening patients with ultrasound, avoiding like a big anterior thyroid artery and avoiding a high riding denominator, that we could safely, at least in our experience, perform tracheostomy in these patients and start anticoagulation. We may deal with some local bleeding. But again, timing is important. Again, it's important to understand the patient. If the patient is on 100% FiO2, 80% FiO2, PEEP of 14, then that's not your patient that you would perform early tracheostomy because you don't know what the outcome is going to be. But if a patient is somebody who has chronic lung disease and now has COVID and is been on 50% and it is day 10, then you could consider that if they're going to require a prolonged wean, especially because of the underlying conditions, that a tracheostomy may be reasonable. And that's why it's important to analyze each patient rather than having a dogma that everything should be done within 7 days, or no, we should not do anything after till 20 days are done.
What you have just said, I think, is very, very important because once again, the individualization of every single patient, trying to adapt the best timing for that patient, avoiding any generalization would be essential. I do have also a technical question coming from the audience, and it's for the three of you. Do you prefer to perform a skin incision before puncturing the trachea or not?
I could go for it first, so that's okay. I mean, so it's interesting, when I was trained originally as a pulmonary critical care doctor, I started with a skin incision, followed by the technique. When I did my interventional pulmonology training, I was shown the reverse, and I've stuck to the reverse. But I don't think, as long as you identify the site correctly, personally, I do a finder needle so that we can identify the location, followed by needle, wire, incision, and then dilation. But I don't see my colleagues do it the other way, and I haven't seen any difference per se, and neither are there any difference based upon studies.
If I may add, we started with just, doing a dilatation technique, but now we take an incision and we dissect up to the trachea, even when we do a percutaneous dilatation tracheostomy, and we use a little finger to palpate the tracheal rings, and then we insert the needle. And I've seen great enough, as Abhinav has rightly pointed out, when we use the ultrasound, and if you don't have a high rising innominate artery, or you don't have, any anterior jugular vein or anything coming in the way, then it's relatively safe to take that small incision and do a little bit of blunt dissection and go up to the trachea.
What about you, Giacomo?
Well, what we do, let's say it's a combination of both. So usually we use ultrasound. So we check the neck with ultrasound before performing tracheostomy. And if we say, let's say, for example, vessels that are very close to the area of the area of incision or of puncture, so then we take an incision and we dissect the tissues, and we ligate the vessels, and we do this together with the neck or thoracic surgeon, especially in ECMO patients. Otherwise, in other patients, we tend to be fully percutaneous if it's possible, because this particularly if the patient needs anticoagulation after the procedure. This reduces a bit the risk of bleeding. But I think that both, if it's very difficult to be completely percutaneous, maybe it's better a small incision of the skin rather than making a lot of pressure with the dilator.
Okay, well, the questions were numerous, so we ended up in a late moment. We are 8 minutes late, so I have to sincerely thank you for your fantastic contributions. It was a beautiful webinar, and I hope that the audience enjoyed all your presentation, as they demonstrated asking so many questions. So thank you very much indeed, and thank you for the audience for their attention. Bye.
Thanks. Bye. Thank you.
Thank you.